Hello and welcome everyone to this webinar entitled Getting the Antimicrobial Message, Results from Canadian Public Opinion Research on Antibiotic Use and Antimicrobial Resistance. This webinar is hosted by the National Collaborating Centre for Infectious Diseases in partnership with the Public Health Agency of Canada. I'm Harpa Eastfeld-Keeley, a Senior Project Manager with the NCCID. Our centre is funded by the Public Health Agency of Canada to provide knowledge and evidence for use in public health planning and policy. Before I begin, I would like to acknowledge that NCCID is located at the University of Manitoba on Treaty 1 territory and the original lands of Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. As a guest on this land, we approach our work with humility to listen and learn, acknowledge past and ongoing harms rooted in colonialism, and dedicate ourselves to actively working toward reconciliation through collaboration with Indigenous communities. Now, to begin our event, I want to share just a few housekeeping items. The chat tab will be used by hosts and speakers for communication with attendees, so please check there for updates. If you have technical problems with Zoom, please send us a message using the email provided in the chat box. And that email will be added to the chat box now. You see that email. And this webinar is taking place in English with simultaneous French interpretation. We're happy to provide that service, and that can be accessed in the interpretation tab at the bottom right. You'll see a little globe there symbol. And there's an option there to mute the original language so that you can listen only to the French. The question period will take place after both presenters have spoken. However, you may enter questions in the Q&A tab at any time. So when the question and answer period begins, I will direct you to the Q&A tab. The recordings of this webinar will be available on our website at nccid.ca under the webcast tab shortly after the webinar. So now I'm going to ask for the poll questions to be put up. Let's start by hearing from all of you. We have just a few poll questions. There's question 1. What describes your current profession? And I see, and we'll just give you a minute to put your answers in. I'm seeing a lot of infection control professionals, policy analysts. That's wonderful. Can we post that result? Okay, very good. All right, thank you. And it's a diverse field, AMR work, and nice to see many represented. So on to question 2 of our poll. Sorry. Question 2, have you taken antibiotic tablets, powder or syrup, IV or injections in the past 12 months? Well, I'm seeing a little under than, yeah, the results are coming in. Okay, we can share those results. So we have 25%, that's, I think that's under the sort of the 30% norms we see somewhere in the surveillance data. Thank you very much. And on to question 3. Drug resistance is when antibiotics are no longer effective in treating infections that will make you sick. Are you worried about this issue? Well, I'm seeing overwhelming concerns, which is, I think, is appropriate for this audience. Very good. And those 2 questions are come from or shared by our speakers today from actually the survey that's. They can comment more on that in our presentation. So, are those results shared, Zishan? I'll share those results. Okay, and on to question 4. Can we post question 4? Does your role involve informing patients, the public, or certain communities about AMR or proper antibiotic use? I'll just give that a minute. Well, this is very interesting. We've got sort of a 50-50 split of people who are actively involved in some of that work. Okay, so we'll close the poll and we'll share those results. Look at that. That's very interesting to learn. Thank you very much for participating in the poll. Okay, so I just want to oh, all right, so we'll remove the poll questions. Okay, so I just have so I just want to introduce our speakers now at this time. Joining us today, we have Anna Louise Craigo. Anna Louise is a senior epidemiologist with the Surveillance, Integration, and Transformation Division of the Antimicrobial Resistant Task Force. She holds a PhD in medical anthropology from the University of Toronto, specializing in social and structural determinants of health. We're also pleased to have with us Tanya Lari. Tanya is the Director of Surveillance, Integration, and Transformation at the AMR Task Force of the Public Health Agency of Canada. Tanya draws on broad experience, having worked on HIV/AIDS policy, family violence policy, children's rights at PHAC, and at women and gender equality, and on the surveillance of mental health, suicide, and family violence. Thank you both for being here today. And now I want to turn the mic over to Tanya, who I believe will begin.
Hi, everybody. Thank you very much. And thank you very much to Harpa and to Margaret, who have been wonderful supporters of our work. This is actually our second presentation this year. Some of you may have attended a webinar in April on the Canadian Antimicrobial Resistant Surveillance System. So thank you. I'm Tanya. As Harpa said, I'm the director of our Surveillance, Integration, and Transformation team, and I'm joined by Dr. Craigo, who is our lead analyst on this file. I want to begin by acknowledging that Canada is the homeland of First Nations, Inuit, and Métis people, and today I'm speaking to you from the traditional unceded territory of the Algonquin and Anishinaabe people. The purpose of today's webinar is to share the key findings of the public opinion research and to identify some key considerations for discussion. And the objectives of the public opinion research are noted here. The planning for this work began back in 2017, and the contract was awarded in 2019. I think we all know what happened with COVID, so the work was extended several times, with the contract finally work being completed by the end of March 2022. Back the Center for Communicable Diseases and Infection and Control was heavily involved in the design of this public opinion research. And I want to thank our colleagues, both in the AMR task force and in CCDIC, for their work on this file. With this work, we really wanted a comprehensive baseline assessment of Canadian public's knowledge, attitude, and behaviors as they relate to antimicrobial resistance and antimicrobial use, in particular antibiotic use. And of course, this data will help us inform the implementation of public awareness and knowledge mobilization, particularly activities focused on World Antimicrobial Awareness Week. This research took place in 3 phases. In the beginning, there was some detailed focus groups to help gather some preliminary insights to frame the survey. And then you see a little bit of a delay between July 2019 and December 2021, a little bit of COVID pandemic happening here. And of course, you know, as we all know, many public health initiatives had to be delayed in order to respond to just the urgencies of COVID. But we were able to get the survey launched in December 2021. 1,515 Canadians completed the survey, and there's minimal weighting applied to the data to have a representative sample of the Canadian adult population by region, gender, and age. And the final weighted sample was 1,500. Nationally, the results have an associated margin of error of plus or minus 2.5% at a 95% confidence level. Results for population subgroups have a higher associated margin of error. And all the percentages that will be reported in this work are based on the weighted sample. And then to complement this quantitative data, we wanted to have some qualitative research done. So focus groups were conducted in small and mid and large size cities in Ontario, BC, Quebec, and the Prairies. Speaking to the strengths and limitations of the data, the large representative sample provided a very good general overview of the Canadian public's knowledge, attitudes, and behaviors. Some of the phase 3 focus groups were specifically structured to include parents of young children and Indigenous or Asian Canadian participants to ensure that their views and experiences were included. Many of the results offer insight into variations by age, gender, education, income, and language spoken at home. And the questions are similar to those done in public opinion research internationally and offer some possibilities of comparability. There are, of course, limitations. The data is self-reported and subject to recall and response bias. As well, respondents did not or may not have understood certain terms in the questions. The results are not disaggregated by racialized or ethnic group. The results include individuals who do not identify as either male or female, but as other. However, the sample was too small to meaningfully interpret these results. The results provide a general population overview and do not provide specific information on the experience, knowledge, or practices of key populations who experience high burdens of various community-acquired resistant infections. The data is descriptive. It's not possible to do bivariate or multivariate analysis. And there is some interesting complementary Canadian data out there. In 2018, there was a rapid response module on antibiotic medication use in the Canadian Community Health Survey conducted by StatsCan. And there's been some interesting work forthcoming from Suzanne Hindmarch and Malcolm King on Indigenous perspectives on antimicrobial resistance. And we expect the report will come out in August or in the fall of this year. I'm now going to turn to Anna Louise.
Thank you very much. So we're going to start by diving into the results, and we'll begin with knowledge, perception, and use of antibiotics. So a large majority of respondents, 81%, correctly identified that antibiotics can kill bacteria. However, almost a third, or 32.5%, said that antibiotics can kill viruses, and close to a third, or 27.9%, said that they are effective against cold and flu. As well, a full 45.8% said that they can treat fungal infections. Next slide, please. There were some sociodemographic differences. So inaccurate information on antibiotics effectiveness against viruses, colds and flu, and fungal infections was consistently reported more often by those young adults between 18 and 24 years old, those with a high school degree or less, and those with a household income below $60,000. To give you one example, a majority of 18 to 24-year-olds, or 54.7%, said that antibiotics were effective against cold and flus, and a full 58% of 18 to 24-year-olds said that they were effective against fungal infections. Next slide, please. When we look to use of antibiotics in the past 12 months, 33.9% of respondents reported that they had used antibiotics at least once in the past 12 months. To note, the period that the reference period of the past 12 months would have fallen between December 2020 and January 2021, during the period where many areas in the country were facing quite high waves of COVID. And we know from the CARS, the Canadian Antimicrobial Resistance Surveillance System report, when we look at dispensing numbers and defined daily doses of antibiotics, that antibiotic dispensing or prescriptions fell quite heavily in 2020 in a way that coincided with COVID and have remained quite low in 2021. So this may be important context to keep in mind in looking at these numbers. 15.8% of respondents had used antibiotics twice or more in the past 12 months, and 4.6% had used antibiotics more than 5 times in the past 12 months. Next slide, please. So if we look at some of the differences, if you look at the top of this graph, you'll see that those with a medical condition report using antibiotics a lot more than other groups. You'll also notice if you scan down a bit that people with household incomes below $60,000 do as well, those who don't have a university education. And when you look at the age bars in the graph, you'll see that 18 to 24-year-olds and 25 to 34-year-olds are reporting high levels of antibiotic use, or reporting more than other age groups to have used antibiotics in the past 12 months. Women are reporting slightly more than men. Next slide, please. If we dive in for just a second at what is happening with young people, the first thing to keep in mind is that it's very likely that we have undersampled the very elderly. So we have a large age group here of 65 and over, and we know from looking at dispensing numbers that there's a real jump between 65 to 79 and 80 and over. So that might be masking some of the differences in use among the elderly and the very elderly. As well, this telephone survey surveys non-institutionalized populations. So elderly people who are maybe living in long-term care or in hospital would not have been reached, as well, even those elderly people living at home who might be quite sick or dependent on a caregiver might not have been in a position to answer. However, it's worth noting that high levels of reported use among 18 to 24-year-olds and 25 to 34-year-olds is consistent with other data that we have in the country. So in public opinion research done in Quebec in 2019 with a sample of about 7,000, 18 to 34-year-olds reported the highest antibiotic use. In 2008 public opinion research in Canada with a similar sample size to this one, young adults were more likely to have recent prescriptions than other age groups. We also know from the Canadian Community Health Survey, where there was a sample of 15,000, that in terms of oral antibiotic use, there were high frequencies in that survey reported among the elderly and among young adults. So young people might consume high levels of antibiotics or due to a high burden of sexually transmitted infections, or possibly due to a high burden of acne that's often treated appropriately and inappropriately with prolonged antibiotic prescriptions. There's also been research in 2 other settings based on electronic medical records in walk-in clinics that found that young adults were the age group that was the most likely to receive an inappropriate prescription for upper respiratory tract infections. Next slide, please. As you may have noticed in the previous slide, actually, can we return to it for 1 second? Thank you. So in this slide, the blue area is reporting 1 prescription in the past 12 months. Orange is 2 to 5 times and gray is 5 times. Yellow is never. And if you look at the overall use is quite high here among young adults, but you'll also notice the overall frequent uses. Next slide, please. So when we look specifically at frequent use, or which we're defining here as 2 or more prescriptions in the past 12 months, the overall total, again, of people reporting that is 15.8%, the first bar you're seeing to your left. But you'll also notice, again, higher frequent use reported by younger adults, higher frequent use reported by people who do not have a university education. Next slide. And then we also see higher frequent use by those reporting medical condition and those who have a lower household income. Unfortunately, because we were unable to do multivariate analysis with this data set to find out, for example, if medical condition might be driving the results we're seeing among those with a lower household income, or not. So this is an area that could be explored in future research, and future research could also look into what medical condition, if any, might be or not associated with higher antibiotic use. Next slide, please. Okay, so now we're going to turn to antibiotic use and health practices. Next slide, please. So respondents were asked to identify their main strategies for making health decisions, and they were given a list of 5 and the option to supply an answer, and multiple answers were permitted. And a very large majority, or 85.6%, reported that they followed the advice of a health professional. However, almost 2/3 report looking up relevant information themselves as a main strategy, and 59.3% rely on their previous experience, and just over 1/3 follow the advice of family or friends. Next slide, please. So when we look at those who follow the advice of a health professional, what's really interesting and striking is that across all of the different sociodemographic groups, over 80% report that this is a main strategy. So irrespective of income or education level, irrespective of age or of language spoken at home, women are slightly more likely to, report this slightly more often than men. However, even men report, more than 80% of men report following the advice of a health professional. Next slide, please. Where we see a difference in strategies is when we look at, again, by age. Now, if you look at the first blue bar here, that's following the advice of a health professional. And I'm going to ask you to disregard that for a moment and concentrate on the orange, gray, and yellow bars. So compared to other age groups, younger respondents reported more often that they followed the advice of family or friends, the yellow bar, based their decisions on previous experience, the gray bar, and or reported looking up health information themselves, the orange bar. Next slide, please. There were 2 cross-cutting themes that emerged in the focus groups related to factors that participants identified as shaping their own antibiotic practices. And the first was the role of difficulties accessing primary care and the time-money trade-offs involved in going to the doctor. So many respondents disclosed that they shared antibiotics or really wanted to get a prescription when they saw a doctor or health professional because of the difficulties of accessing care, or the challenges of being able to get a prescription later if one was eventually needed for them or for their children. And previous research has identified the challenges of accessing care, in particular in relation to gendered care burdens, as a factor in antibiotic use and inappropriate antibiotic use. Similarly, women in North Battleford, Saskatchewan, where there was high Indigenous representation, noted that it was common practice in their communities to keep antibiotics from a prescription for later use due to the lack of access to a doctor and the challenges in seeing a health professional. This may be a dynamic that particularly affects remote and or Indigenous communities. Other research, such as that by Williams and colleagues on antibiotic use in the Arctic in 2019, linked high rates of antibiotic use in remote and or Indigenous northern communities to, among other factors, lack of access to a physician and lack of access to diagnostic tools. Another cross-cutting theme that emerged in the focus groups was the cost of prescriptions and the financial pressures on families. And so this was cited by participants as a reason for sharing prescriptions or for keeping old pills. And it was also the main reason cited by a small number of respondents for purchasing large quantities of antibiotics abroad, or having a member of the extended family do so for their children's eventual use in Canada. Next slide, please. Now we turn to knowledge, awareness, and perception of antimicrobial resistance, or AMR. Next slide, please. So the first thing to note is less than 1 in 4, or only 24.6% of Canadians report that they are familiar with the term antimicrobial resistance, or AMR. If you look at, that's the yellow bar. If you look at the gray bar, a small majority, or 50.9%, are familiar with the term superbugs. However, that really depends on the language spoken at home. So only those who reported speaking English at home, only among them did a majority say they understood that term. Far more familiar with the terms drug resistance and antibiotic resistance that were known respectively by 66% and 68% of respondents. Next slide, please. When it came to personal experience of antibiotic resistance, or AMR, 22% of respondents said that they had experienced or knew somebody who had experienced antibiotic resistance. Now, this fell to 8.4% for AMR, most likely due to a gap in understanding of the term AMR. In focus groups, however, it was very uncommon to have experienced or to have known somebody who had experienced antibiotic resistance. When it comes to concern about antimicrobial resistance, once provided with an explanation, a simple explanation of what antimicrobial resistance is, akin to the one you were given in the polling question, a majority, or 57%, expressed concern. However, in the focus groups, AMR was not seen as a top 10 global public health threat. It was not viewed as a particularly urgent or concerning issue, and respondents largely felt that it didn't concern them, their families, their communities, or even their geographic regions. Indigenous respondents reported in the focus groups that they were facing more pressing issues such as systemic racism and access to clean water. I will note that there was larger concern around overuse of antibiotics in Canada. In the focus groups, when that specific concern was explored, the respondents didn't tie it to a concern about resistance, but rather to their general view of healthcare, perhaps a skepticism of biomedical institutions in general, or a view of more acts on preventive or holistic healthcare, but not specifically around concern about resistance. The other major concern in the focus groups around overuse of antibiotics was specifically about side effects. And in the focus group, in the survey, 46% of respondents expressed a concern, a reluctance to use antibiotics due to concerns about side effects. Next slide, please. So now we're going to turn to some comparisons and considerations with other public opinion research. So in 2008, there was public opinion research done in Canada, a nationwide survey with a similar sample and a similar methodology. And what we see is over the past 14 years, a slight decline in the proportion of Canadians reporting antibiotic use from 38% to 34%. This is consistent with what we see with prescription data, where there's been a very slight decline over the past 14 years, and then a much more rapid decline that coincides with COVID. In terms of knowledge, so fewer people, a smaller proportion are reporting that antibiotics kill viruses, but not by a lot. So 33% versus 39%. The next question is an imperfect comparison, but nonetheless a point of reference. So in 2008, 24% reported that antibiotics were effective against colds. And in this public opinion research, 28% reported they were effective against cold and flu. Notably, concern about antibiotic resistance was at 59% in 2008 and is at 57% in this research. Next slide, please. Here, you'll notice the tables in English are at the top and the tables in French are at the bottom. If we compare ourselves to other public opinion research done in other high-income countries, Canada fares similarly to the UK, which is consistent with what we see for prescribing defined daily dose numbers. We fare a lot better than Australia, which is notably an outlier known for its real challenges in reining in antibiotic use. But we lag far behind Sweden, who's been a country that's been very successful in curbing antibiotic use in the population. In terms of knowledge of antibiotics, if we look at this one point of incorrect information, the idea that antibiotics treat viral infections, Canadians report it at similar rates to other countries, as to some of our other high-income peers. When it comes to concern about drug resistance, however, a lot smaller of a proportion of Canadians report concern than other countries. And now I will turn it back over to Tanya Larry.
Hi, everybody. So that last slide showed this kind of rather troubling finding that far fewer respondents in Canada are worried about AMR than in other high-income countries. There's a real perception that antimicrobial resistance is not here yet, or it's over there. And we looked to the CDC 2019 report, which had some very good examples of messaging to target such beliefs, which we might use to inform campaigns in Canada, such messaging such as Everyone is at risk. Antibiotic resistance has been found in every US state and in every country across the globe. Stop referring to a coming post-antibiotic era. It's already here. And I'm going to turn now to the next awareness slide, which is the focus on young adults. In the findings, young adults report very high use of antibiotics and the very high frequent use of antibiotics in the past 12 months. They also had less information on appropriate antibiotic use, less familiarity with AMR-related terms, and were more likely to use health decision-making strategies that put them at risk of misinformation. And we know that in other research on health in general, that young adults are more vulnerable to health misinformation. Young adults are also frequently the parents of younger children, so they're really an important group to consider in health promotion. Turning now to equity, we have this real issue that came up in the focus groups, and that really shows you that, the value of those focus groups, where people, particularly those in remote and Indigenous contexts, raise the challenge of time and money trade-offs related to accessing primary care. And they raise this in relationship to pushing for an antimicrobial prescription, reusing or sharing prescription. And we know that this really pushes towards implications for stewardship, to consider strategies that account for these difficulties, particularly for the parents of young children, women, and or people in Indigenous and remote communities. Delayed prescriptions may alleviate concerns about the time and money constraints of accessing future care, and rapid diagnostic technology may be worth prioritizing for remote and Indigenous communities and remote healthcare settings serving many young children, to alleviate the concerns of needing to return later for a prescription. Another equity consideration that came up was that people with lower income levels had much higher frequent use of antibiotics. This may be linked to a higher burden of medical conditions or to lower vaccination rates in lower income communities. People with lower income levels also appear to have a high risk of certain infections, including infections with antimicrobially resistant pathogens in Canada. Those with low incomes also have lower knowledge about antibiotic use. And we also heard that financial pressures and economic constraints informed antibiotic use practices. However, individuals with low incomes do express high trust in doctors as a source of health information, and a large majority follow medical professionals' advice in making health decisions. So this gives us a real opportunity for positive impact on antibiotic use among people with low incomes. And just flagging that stewardship initiatives should consider these role of economic constraints. And then the final equity consideration is that while the collection of race-based data and ethnicity-based data has expanded greatly in some provinces during COVID, there is still a lack of data on both antibiotic usage and antimicrobial resistance. Research in other contexts has shown significant difference in antibiotic use, antimicrobial knowledge, and experiences of AMR infections according to race and or ethnicity. Race-based and ethnicity-based data is key for effective and equitable stewardship and health promotion efforts going forward. And there are some very good Canadian best practice and guides with regards to ethical and respectful collection of race-based and ethnicity-based data. And research led by or in partnership with affected racialized communities can help us to fill this gap. In conclusion, this public opinion research has shown us that very good information on the knowledge, attitudes, and the perceptions of the general population. However, important gaps remain in the understanding of how these attitudes play out in key populations at higher risk and in high risk environments. Next slide, please. So here are some of the additional sources we consulted. And next slide. I want to thank quite a few people here at the Antimicrobial Resistance Task Force and the Center for Communicable Disease and Infection Control. Anna Louise Crago for her leadership on this, Stephanie Alexandre, and Jackie Arthur and Jennifer Shishun, who really got this project off the ground. So thank you very much. I also want to thank Strategic Council, who did this project for us, and our great partners at the National Collaborating Center on Infectious Disease. Thank you very much. Back to you, Harp.
Thank you, Anna Louise. Thank you, Tanya. Excellent presentation on the summarizing the findings of this research, and so important to our continued and concerns for increased awareness building in Canada. And I want to turn us now to the Q&A period. And so you'll see the Q&A tab if you've got it on your desktop of the second tab, and we already have a few questions come in. And I'm going to begin with those. We also have some questions that were sent in as part of your registration, some advanced question. But let's start with the Q&A pod. A question from Nick. Was there a specific question on purchasing antibiotics abroad or online?
Anna Louise, do you want to take that one?
That's a really interesting question. In the focus group, there were in the third phase, there were specific questions about purchasing antibiotics abroad. There weren't questions about purchasing antibiotics online. However, and there's very little known about whether or not that's a trend in Canada or not. There have been studies, notably there's one in Italy, that found that young adults who were reporting very frequent antibiotic use were frequently self-prescribing or taking unprescribed antibiotics by ordering them online. So it is a really interesting question.
Okay. Anything to add, Tanya, there? No? Okay. Yeah. Thank you very much. And a question from Amy. What strategies do you consider beneficial to increase awareness and interest of the risks and impacts of antimicrobial resistance among the general public? So taking it all in your research, are there some high points here you can call out for, what's working? What do you suggest?
I think we can answer this not just from this research, but also from some of the other research we've consulted, which is really that you need a kind of multi-pronged approach, and that public awareness in and of itself is not going to change. You need very good stewardship, and you need to also be communicating with people at the moment, or when, like in a healthcare setting. We're at a time when this is top of mind. For many people, AMR is not on their top 10 health issues. So you need to target the messaging. You need to very much work with healthcare professionals on stewardship. However, there have been some very positive campaigns elsewhere, which I'll turn to Anna Louise just to speak a little bit more about that. But one of the things that really came out in the focus group is how complex the issue is to explain to people, and that it's not, people kind of struggled with the definitions and trying to understand the issue. So they needed a little bit of a primer, and then they could answer questions. And Anna Louise, I'm going to turn to you because you've really looked into this research.
So there have been some systematic reviews that have looked at what awareness campaigns were successful and how and what they did. One of the more recent ones found that awareness campaigns that were multi-pronged were more successful. Another one found that those looking specifically at messaging around respiratory tract infections and how antibiotics were not necessary for treating most of them were more effective than sort of more general, broad information. On the other hand, there's also data from campaigns that did campaigns specifically on respiratory tract infections that did not show evidence of an impact. So it's a bit complicated. There have been different approaches around messaging. So one approach has been to sort of appeal to the future concern around antimicrobial resistance. In Sweden, that has had a very successful approach that has not been axed on, that has not had as a core focus awareness, but that nonetheless does do awareness. their messaging really focuses on side effects and on the risks to the individual person taking the antibiotics is the core message. And one of the things that struck me in this public opinion research is there is almost half of respondents who are really concerned about side effects of antibiotics. So there is concern about taking antibiotics, although that concern may not be linked to resistance, it might be linked to other things. There's something interesting to possibly explore there.
Okay, yeah, so to leverage that concern and pair it with other concerns about AMR, as we buy some time to also unpack and explain this complexity. That's, yeah. Well, thank you both. I'll just move on to next question. Do the higher rates of prescribing in youth, younger adults align with surveillance data? BC data suggests that antibiotic prescribing increases with age, with young adults prescribed a relatively low amount. I think you've addressed a little bit of this about some of the sampling issue. More to say, Anna-Louise?
I can also hopefully link Stephanie in to answer as well. My understanding is when we in the CARS report look at defined daily dosage, we're looking at tonnage, and tonnage is a lot higher with age. I do think that in the public opinion research, we very likely undersampled the most elderly, and that you would expect to see higher rates with the elderly. But as I mentioned in the CCHS survey, which was specifically on oral antibiotics, there were high frequencies reported both among the oldest and among the youngest adults. So that it's consistent with some of the other data we have. But certainly it seems that tonnage of antibiotics is consumed more with age when you look at the defined daily doses in the CARS report. But Stephanie, can you perhaps correct me if I'm wrong on that?
Stephanie Alexander is our manager of the CARS surveillance report. So we're just looking to see, you know, Nick, we may have to get back to you on this. Certainly one of the strengths, but also the challenges of the CARS report is we do have this national level data, and we can do, and it's, the data is on consumption, you know, it's on sales of antimicrobials, not on actual usage. But I think what Anna-Louise said about the, you know, the DDD, the defined daily dosage is correct, but there are different patterns in different provinces. And we do see, you know, that age, there is a bit of an age gradient, but young people do seem to use a lot of antibiotics. And we can get back to you with a more concrete answer, Nick.
Fair, thank you very much. Just so to move along, we also have a question about the impact of telemedicine on the purchase of, well, on the purchase of antibiotics is the question. Is can you comment based on this data anything about telemedicine's impacts?
Not based on this data set.
Mm-hmm. Yeah, and what else do we know about telemedicine's effects on usage rates? And maybe that's something
we need to look into further. It definitely wasn't a question asked in this research, and I think it would be a very interesting question. We're going to be able to access at the Public Health Agency some more data sources like electronic medical records, and we should be able to start to get a better picture of antibiotic usage in Canada through some of these emerging data sources. Right now, we're really using sales data of antimicrobials as our main data source, but we are bringing online, you know, several new data streams that will help us better understand this picture.
Okay, thanks. That's great. We have the task force people with many roles and hats here to draw in on the surveillance issues as well. And of course, this research is more based on some of the awareness pieces that we have learned about. So I just want to look at the next question of Jason Van Stone. Thanks, Jason. Our antimicrobial stewardship program provides education to local high schools to increase awareness on appropriate antibiotic use in AMR. It appears that this might be an even more useful undertaking than I had initially suspected based on the high level of misinformed younger adults. Does PHAC have intention to support awareness campaigns of this sort nationally? Can we hazard an answer there?
Yeah. Well, we of course support the World Antimicrobial Awareness Campaign every November, and we'll, continue to do that and putting a lot of resources into planning that campaign. So that is where we're at now. We are always sort of exploring new opportunities, but there are always constraints to unavailable funding. But our focus nationally is really on the World Antimicrobial Awareness Campaign.
Yes, and I think we'll comment more about that. There's many of the attendees I think are involved in a collaborative group that NCCID leads and partners with PHAC, and so our ears are open to this research right now and looking at just these kinds of points to help shape the coming November's campaign that's aligned with World Antimicrobial Awareness Week in November. So I think this is a good point to call all our attention to. Francois's question, have you considered integrating the diagnostic practices as part of your research? For example, do people accept or not taking antibiotics with or without a confirmed diagnostic? And I welcome also participants to write comments in the question box if you have some experience that relates to some of these questions. Do either of you want to weigh in a comment?
Anna Louise, do you want to take that one?
I think it's a terrific question. It wasn't part of this research, but I certainly think it's one worth exploring in future research.
Yes, yeah, very interesting. And of course, strategies like the delayed prescriptions, hinge on that piece of information, but commenting on like awareness of the diagnostic results is key. And of course, there's equity issues about some of the lab access and diagnostics issues of remote communities, etc., that relate. Very interesting, interesting point. Lydia's comment and question. Thanks for sharing the Canadian CAP data and also comparing internationally. How much headway has been made in influencing dispensation behavior as a source control and in disposal practices and education? So that's maybe an aligned topic, not directly on awareness. And any takers on the question? Any added information we can put to that point?
Well, we know that there are multiple sources of influence in the stewardship file, most particularly in hospitals and in provinces and territories. And we know that nationally over 5 years, we see a slight downward trend in human consumption of microbials purchased by hospitals and by retail pharmacies. But there's a lot more work to be done in stewardship. We know that there are many inappropriate prescriptions in Canada. There's a lot of emerging work on that. And, we certainly see this as one of the biggest gaps in the AMR response. And I hope that answers your question, Lydia. Nice to see you.
Very good. And Jason is asking if there's a national group that can produce and promote national advertising about inappropriate use of antibiotics for URTIs, especially during cold and flu season. This would help make more people aware of the issue of AMR and our ability to affect it by our use of antibiotics. I can say that the collaborative work we've done on awareness building during World Antimicrobial Awareness Week has often picked up on the URTI issue specifically as a theme. And we need to get that message out certainly stronger and bigger. There may be other national organizations that are fitting and who can speak in that to the issue. Tanya or Anna Louise, any interested points on stakeholders that can be voicing that, national groups? Or
I think Choosing Wisely Canada is a great model for their work. And I don't know if anyone from Choosing Wisely is on the call, but for their work on inappropriate use of antibiotics. So that's the model that we really look to. And also, of course, some of the work through BC CDC, Do Bugs Need Drugs. So
yeah, antibiotic wise, that arm of Do Bugs Need Drugs. Yeah, really good. Just going on to Frank's question, it would be good to examine the impact of high concerns on AMR. It could have negative impacts such as less respect of health guidance from public authorities, washing hands, etc. We could adapt messaging accordingly. I also wonder if the high sensitivity in the UK may have explained high COVID and mortality rates earlier in the pandemic. Yeah, either of you want to take that question?
I see it more as a comment. Really interesting
Yeah.
question about the UK, and I do think all of these responses to AMR interplay with all kinds of other things: infection prevention and control, hand washing. General, we see an increasing, sort of suspicion of healthcare, public health advice, and mistrust sometimes of healthcare professionals. Although I did find this survey findings here that over 80% of people did look to healthcare professionals to be quite reassuring. But there's a lot going on in the public health space right now, and these are all concerns that are worth looking at.
Very good. Okay, I want to take questions from some of the new questions, new people on the line there. I'll come back to others. It looks from Oscar, it looks like the use of terms antibiotic and antimicrobial yield different results on awareness level regarding the familiarity with AMR. Would you therefore advise the shift from the use of antimicrobial to the use of antibiotic whenever applicable in order to impact public awareness of AMR? And that's timely, like the World Health Organization just shifted a couple of years ago to the use of antimicrobial in the global campaign. And so we were following suit. I can comment that the way that the collective has addressed this is to use both terms, use antibiotic and other antimicrobial. We've also used drug resistance wording, and I'm really happy to see a good awareness of that. Do either of you like to comment further on the question?
I really like the approach of using both because, language changes and it will take a while for that term to stick. I know lots of people who work in health, but not in this area, who are not very comfortable with the terminology, and that, but we also know that language changes, and we do learn how to use and understand new terms. Anna Louise, did you have anything to add?
I just wanted to say that on the one hand, it's a very low proportion who recognize the term antimicrobial resistance. On the other hand, if we think that it was relatively recently introduced, a positive way of looking at it is that close to 25% now recognize it. So that's potentially a positive in terms of increasing awareness of the term over time. But I also think linking them is very helpful.
Okay, really good. And just wanted to flag that Jason added information that the CPC SSN might have data about telemedicine use and antibiotic prescribing rates. I'm not familiar with the acronym. What's the?
I think it's the Canadian Primary Care Sentinel Surveillance Network.
Yes.
And that is the record system that FAC is working we're not there yet. We don't have data yet. We are working to access this data.
Okay, great. So Jason is helping plug
Thanks,
plug your
Jason.
progress. And I want to go back to, and this is a question we got it also in advance. I want to give those some airtime. A lot of antibiotics are destined for use in food-producing animals. Is a One Health approach, including AMR in agriculture, used in awareness campaigns for AMR? Very excellent question.
That is a really interesting question. I know that our colleagues at the Center for Foodborne and Zoonotic Infection are actively working to plan the activities for World Antimicrobial Awareness Campaign. We're certainly at the agency trying to take a One Health approach in general, and our surveillance data does look at both human and animal usage of antimicrobials. But that is a complex file, and it certainly there has been a lot of work done over a long time on that file.
Yes, and as part of the collaborative campaign, we're just this year doing edits to the page to be more inclusive in our language about One Health. So you'll see those kinds of edits in the campaign that I'll tell you a little bit more about as we close. But we're also looking at, there's such good work done by some major organizations in that space, in the animal and agricultural fields, and it's like tying and linking to their work. I think that generally, some of the human health side is a little bit, not integrating altogether well and aware of what each other is doing in this space, and there's some good tie-ins that we need to do. Going to Jason's comment, COVID is a perfect springboard for discussing inappropriate antibiotic use. Any thoughts on using a hot topic to highlight the ensuing AMR wave we are likely to see?
I think that's a great discussion that we should be following, and we're really interested in seeing Canadian data. We've already seen some fascinating data from US CDC looking at a 15% increase in certain resistant infections and in mortality. Canadian data is not there yet, but I think we saw first a huge decrease in antibiotic usage, and then we saw an increase in inappropriate antibiotic usage. So it's the story is complex, but I think it's definitely worth discussing and investigating. And I know there's a lot of work underway, both at the agency, but across Canada on this topic, because it has been such a huge influence on antibiotic usage in two different directions. So we will see. So yes, Jason.
Thank you. And as we have little time left, I'm just going to touch on one advanced question that came in to us. How has the concept of individual responsibility impacted AMR attitudes? How has the loss of institutional credibility impacted efforts to communicate about AMR and audience response? Anyone have any opinions to bring forward on that point?
I'm going to turn to Anna Louise for this one.
I mean, I think one of the things that we're seeing that was noted for COVID is this concerning trend of particularly young people turning to sources of information for their health-based decision-making that put them at higher risk of misinformation. I think that the lack of trust, we've seen the impact of the lack of trust on things like vaccination uptake for the COVID vaccine, and particularly for the third dose among young men, that same demographic. And there's a potential reason for concern if we're looking at vaccine-based AMR prevention strategies, that when there's distrust of public health institutions, there can be distrust of vaccination. And we know that, for example, things like universal flu vaccine had really important impacts in Ontario, for example. and can be very powerful tools in terms of antibiotic usage and combating AMR. So that is a concern. It also plays into that interesting question of sometimes, whether or not we agree with it, messaging about the greater good and future risk to the greater good is less easily absorbed and translated into people's own individual health decisions. And it raises questions about Sweden's approach of talking to people about individual potential negative or side effects of antibiotic consumption on their own health, and how that may or may not be something to explore when there is suspicion of public institutions and potentially less adhesion to or less responsiveness to when messages around the greater public good.
Right. Well, it's a complex topic, and we could go on. And I'm looking at the time, and with some guilt, I've taken you to the very brink of it. I do want to thank both our speakers, Tanya, Larry, Anna Louise. This has been excellent. It feeds our campaign planning. I'd like to, if Zishan, you can type in the chat box, antimicrobialawareness.ca is a website that that NCCID manages. That's a collective campaign. A lot of the of PHAC and others that are involved in campaigns and work in this area do a campaign every November, and we're learning from this research right here. So I do invite you to look into that this November, and follow us on Twitter if you're interested in that work. And also certainly look for the report. We're interested to learn about the Indigenous results from Hindmarch's and King's report that was referenced in this presentation. Look to that in the fall, as our speakers have said. Thank you both. Thank you to our my staff members, Zishan and Chris, who are helping on the back end, and to Megalexis, who's providing interpretation services. Thank you all for joining us today and taking the time. I'll just turn to the speakers for your close. Goodbye, everyone.
Thank you very much. And thanks for the great questions. It was really fascinating to see, and hope we'll be able to follow up on a couple of them. A great discussion. So thank you. And thanks always, as always, Harpa.
Thank you both. Goodbye, everyone.